Okay, let's turn to page 115. Turn to page 115. Okay, yesterday we continued on with the Inhalation Anesthetics. I want to wrap it up today. It's time to move on. And so, just to backtrack a little bit, mostly talked about toxicity yesterday. The fact that there are several associated side effects. One being the issue of developmental neurotoxicity in children, which is still very much up in the air and being looked at actively, very actively, as of right now, by all the appropriate groups, as to whether young children under 3 years old, when they're subjected to surgery and anesthesia, can have any long-term effects. So far, none have been proven in humans, real kids, but animal studies have shown some difficulties. Also talked about OB, the use of anesthesia drugs in pregnant women, and what if you have to put a pregnant woman to sleep for a non-obstetric reason, emergency type procedure. What about the use of inhalation anesthetics? And the answer was yeah, you can use them, except for nitrous oxide. Keep the concentrations low so you don't relax the uterus too much, and use a lot of narcotics technique. That's usually what we do. A little bit about POCD, postoperative cognitive dysfunction, which is confusion that occurs for several days post-op in some elderly patients. May be associated with just the process of having surgery. But certainly the anesthetic drugs contribute to that somewhat. We are giving potent sedatives, so it's not surprising that in some elderly patients they can have some cognitive effects. They're usually not long-lasting, but they certainly happen. Then I also talked about what they've coined ED, emergence delirium, in children, and that is young children, certain amongst them, can wake up very combative, very transient effect. It only lasts 10 or 15 minutes, and requiring a little bit extra nursing care on the part of us and the PACU nurses, mostly PACU nurses, but it's not a permanent issue. And then we talked about nitrous oxide and immune suppression, the fact that it inhibits vitamin B12 cofactor to the enzyme methionine synthetase, which is required to eventually synthesize many immune products in the body, including DNA and RNA and other products. And that with prolonged exposure, usually greater than 6 hours, in less than healthy people, you can get some issue. So I think that's kind of what I left off with yesterday. So I wanted to go to, if there's any questions on any of that, let me know. I wanted to go to page 132 and start up new for today, and just very briefly look at a couple figures. Let me go on the camera here. This one we looked at before. I'll do it again, and I'll talk a little bit more in the second hour. This is just looking at recovery, and, well, let's read what the fellow says here. Rapidity of recovery following anesthesia is inversely proportional to the solubility of the anesthetic. This is pretty common sense, right? As an anesthetic is very soluble, it's going to be slow, so it's going to be slow going in and it's slow coming out. So that's basically the take-home message. The difference is amplified by the duration of anesthesia. In other words, the longer the case, the more anesthetic drug you pump into the person, the longer it's going to take to get it back out of the person. That's common sense. Right? So if you look at the figure, DES being the least soluble, and these are plotting how many minutes it took to recover from 0 to 2.5 hour case, giving 1.6 times the MAC, which is about the MAC 99. And with DES, doesn't matter pretty much how long you give it. It comes out relatively quickly. And you see, I'm going to eyeball this a little less than 10 minutes maybe to wake up. If you turn the dial off at nearing the end of the case when they're getting ready to staple, or put the dressing on at least, and within 10 minutes the patient should be responding to commands and waking up. SIVO, not much difference. Isoflurane, of course, is going to be slower, and halothane we don't care about, but that would be slower anyways because it's more soluble. So the longer the case, the sooner you have to turn it off with the more soluble agents, I guess. That would be the practical upshoot of this. So hopefully that makes sense. And then I want to share this. Very important. Page 144. And this shows that the MAC values are increased in redheads. On average, redheads require 20% higher DES to prevent movement. So this is a scattergram of the dark hair people and the scattergram of the redheads. What does it mean? I have no idea. I just thought it was cute. Okay. Now let's try to kind of mop up some of these extraneous things. So let's go to page 145 and just kind of cover what I haven't covered yet. And these are key points. I like these when they do them in books. If you haven't noticed, I'm a fan of these kind of ways to summarize things. And this is from Dr. Barash's book, Clinical Anesthesia, one of the famous anesthesia textbooks. And it was just published a couple months ago. He's got a 2017 edition, so these are brand new. So let's go through some of these. It's a nice way to summarize, repeat, refresh, etc. I'm on page 145, number 1. At equilibrium, the CNS pressure of an inhalation anesthetic equals the arterial pressure, which in turn equals alveolar pressure if cardiac is normal. So in other words, the amount in your lungs is going to be the amount in the blood. They're going to equilibrate. That's pretty straightforward. Number 2, the inspired concentration and the blood gas solubility are the two major determinants of speed. So how high you turn the dial on, plus the natural speed of the drug itself, blood gas solubility. I would add a third in there and say ventilation. Those are the big three. The three most important factors on how fast someone goes to sleep are ventilation, concentration, and blood gas solubility. Solubility alone determines the rate of elimination, provided there's normal cardiac function. So. Number 3, fluorine is the most potent of the anesthetics. DES is the least soluble, therefore fastest, and SIVO is the least irritating to the airway and therefore used for mask induction. Nitrous can expand a pneumothorax to double or triple its size, and the washout of nitrous can lower the alveolar concentration of oxygen and CO2, which is called diffusion hypoxia. The MAC is the amount required to prevent movement upon surgical stimulation. It's a MAC 50. MAC decreases approximately 6% per decade. Hey, I didn't know that. 6%. Sure it isn't 7%? I was wondering, medical books are so precise. 6%. So obviously a 70-year-old patient is going to take less than a 7-year-old patient. And if you did the math, since that's 7 decades later, he's older by, or she's older by 7 decades, that would be 7 times 42% less in a 70-year-old than a 77-year-old. Exactly 42%. Number 7, volatile anesthetics depress CMRO2 and increase cerebral blood flow in a dose-dependent manner. The latter effect may increase ICP in patients with tumors and space-occupying lesions of the brain. Hyperventilation or hypocapnia can abolish volatile anesthetic-induced increases in cerebral blood flow, depending on when the hypocapnia is produced, and so on. So you can just hyperventilate a little bit, and it's not clinically relevant. Number 9, volatile anesthetics produce a dose-dependent depression of pretty much everything CNS-wise, EEG, sensory evoked, and motor evoked potentials. Number 10, the anesthetics in current use decrease pressure, vascular resistance, and myocardial function in a dose-dependent manner. In the same time, number 11, they depress respirations, tidal volume, respiratory response to carbon dioxide, etc. Relax smooth muscle. Volatile anesthetics, in the last, number 12, in current use have minimal adverse effects on the liver and in fact may be somewhat hepatoprotective. Next, page 146, number 13. Volatile anesthetics are potent triggers for MH in patients who are susceptible, genetically susceptible, except for nitrous oxide. He didn't put that in there, I did. Number 14, CO2 absorbents degrade SIVO, DES, and isoflurane to carbon monoxide when the normal water content of the absorbent, which is supposed to be around 13 to 15%, is they dry out. The granules and the carbon dioxide dry out to less than 5%. You can produce some toxins inside the machine. Now, I have a little blurb about this, and I just want to talk about it. I don't think it's really clinically that important anymore, but something, hopefully, whoever, when you learn the machine, or I'll let you talk about it, but I do have a little write-up, and I'll find it for you right now. It is on page 1. I had it tagged and then I moved it. Here we are. Page 122. Page 122. All right, now this is a reaction that occurs with the anesthetic gases in the machine. This is not in a patient, all right? This is something occurring in the anesthesia machine. And so I put a little blurb about it on page 122. But let me just talk about it for a second. All right. One of the toxicities that was noticed with sevoflurane was that it reacts with the carbon dioxide granules, specifically Sodaline, the brand. There's several different brands. For those who haven't had it yet, there's many different brands of carbon dioxide granules. There's Coke, there's Pepsi, there's RC Cola, you know, there's different brand names. And your hospital system can buy whatever they get a best price on. And so, you know, when you go to different hospitals, everybody's using a different brand. Certain brands of the granules react with SIVO and produce a toxic, trace amounts of a toxic compound called compound A. We just named it compound A rather than used a long chemical name. And compound A in animals studies has been shown to be neurotoxic and renal toxic and just toxic. It's bad. And so and it was noted that two things. When you put low flows on, in other words, when you carrier gas, you turn those dials, remember I showed you on that little thing with Jeremy and I made the movie, when you turn the dials real low to save money, so the gas is flowing slow through the machine, and it's lingering longer in the CO2 canister. And the longer it lingers, the more toxin it can produce. So the FDA, in fact, I still think it says this in the package insert of SIVO, although I haven't looked to see if they changed it. But they say that if you're using SIVO, you shouldn't use gas flows of less than 3 liters per minute, because then the gas will be moving faster and you'll have less chance of making this compound A. So we're supposed to use, quote, low flow anesthesia when you use SIVO. Well, we solved the problem because the companies, fortunately, went back to the drawing board and made new CO2 granules that do not react with SIVO. So it's pretty much a classroom thing nowadays. It's a moot point because everybody stopped using, within the last few years, these carbon dioxide granules that do react with SIVO, and now we all buy the new stuff that doesn't react with SIVO. So it's not really an issue anymore. Although, like I said, I don't know if the FDA has actually changed the package insert to note that. So, although there can be toxins made in the machine, it doesn't happen anymore because everybody stopped using the type of CO2 granule that would cause the toxicity. And they all use the brand new stuff. Secondly, it's noted that what happened was there's some machines, let's say you had a machine here, you put it down in an x-ray, you're in the anesthesia department, you put it down in an x-ray, and maybe they only use it once a month. You know, sometimes you get sent down to x-ray to help with some case, and rather than lugging anesthesia with three stories down or whatever, they just kept the old machine down there, so you'd have at least some kind of machine to give anesthesia from. And it was rarely used, so they didn't really maintain it on a daily basis like you probably should have. So what happened was the carbon dioxide granules would dry out, and they were old. And so somebody would go down and use the machine for some case, an x-ray or some, out of operating room procedure of some kind. And they'd flow some gas through it. And what they found out is when the granules dry, then you can produce carbon monoxide. And the patients, of course, that's toxic. Now, nobody got hurt, and the levels are pretty small. But nonetheless, you don't want to be giving bad gas to people when you give them anesthesia. So the point is, you have to maintain your machines. This is a maintenance thing. And before you use a machine that hasn't been used for several weeks, you should change the CO2 granule, the canister, so you have some fresh stuff in there, and then it's got moisture, and then you're not going to have an issue. So these are two toxicities that occur in the machine related to the inhalation anesthetics, both of which are, the compound A thing is pretty much a historical lesson now because we don't use the type of granules. But even the thing with carbon monoxide is preventable if you just, properly take care of the equipment in the department and don't use expired CO2. So let's take a look at page 122 and see what I have to say. Oh, this is from Barrage. Several decomposition products are formed during the interaction of SIVO with CO2 absorbents. Soda lime was a brand name, like a Coke or a Pepsi name, and Barrelime is another one, and then they were the ones that reacted the most. And I bolded this sentence: the new absorbents currently used do not react with SIVO. So what does it mean in clinical care of the patient? Typical levels seen were not enough to harm anybody. Nonetheless, you don't want to be giving bad gas trace amounts to a patient. It appears from studies, lower threshold for renal changes, compound A is 150 parts per million per hours, and a fresh gas flow of 2 liters per minute. These would be expected to see only under severe conditions. So the point is, maintain your machine and don't use old equipment, and the patient will be fine. So these are kind of classroom things to talk about. Okay. Now, I want to also go to, let's go to page 146. Page 146. This is a little table of parameters, physical and chemical parameters on page 146 of the different gas anesthetics. And normally I wouldn't worry about put this on there. Like I said before, I'm not a fan of memorizing numbers. That's what books are for. You can look it up. Don't really need to know this stuff too much for clinically. But because these are the gas anesthetics and they're our bread and butter, the most important drugs we give on a daily basis to every patient, then we should at least be familiar with all of the different aspects. We're supposed to be the hospital experts on these things. So I did want to go over a couple things. So let's look at this. Page 146. The first property is the boiling point of the liquid, degree centigrade. And you'll notice that with nitrous it's irrelevant because it's under pressure. But for the volatile drugs, SIVO is 59 degrees, isoflurane is 49, but DES is 24. So what does it mean? Well, it means that desflurane will boil at room temperature. What's room temperature? How many degrees?
75.
Yeah, 75 Fahrenheit. How about centigrade? 36 is body temperature, so 30, 28, something. This is 24. What it means is if I have a bottle of DES, I unscrew the cap, just leave it out to the air, it's going to boil. Because the boiling point's lower than room temperature. See that? So the desflurane bottles come specially designed so you can't take the top off. There's no way to open it. And so in order to use it, fill a vaporizer, you have to use a little wand-like looking apparatus, a straw thing. You put it in the top, you put it in the vaporizer and pour it. So desflurane, you can't open the top because the boiling point is a little bit lower than room temp, meaning that if you expose the liquid to air, it would start to boil. And you'd go away and you come back and your bottle would be empty, the room would be all stinky, and you just cost yourself $200. So that's the boiling point. All right, the vapor pressure of the gas. Vapor pressure is the atmospheric pressure at which a gas will vaporize into a liquid. All right, if you remember way back to high school physics and chemistry, it had to do with STP. The scale is 0 to 760 millimeters of mercury. If a liquid is at 0, it's not going to be able to be vaporized into a gas. If the liquid was at 760, it wouldn't be a liquid anymore. It would be a gas. So the scale is between 0 and 760. The higher the number, the closer to 760, the easier it is to change that liquid into a gas. All right, so look at these numbers. Again, nitrous doesn't count because it's under pressure and all that. But which of these drugs is the easiest to vaporize, would you say? Would be DES, right, at 669. What's the next most easy to vaporize? Isoflurane at 180, I'm sorry, 238, and then finally sevoflurane at 157. Now, does this matter to anybody? No, we couldn't care less. It matters to the guy who makes the vaporizer, because they've got to design a vaporizer that's specific to this drug, because it's the boiling point, the vapor pressure, the physical properties of that liquid have to be taken into consideration. So then when I go in the OR and I turn the dial to 2%, 2% is coming out. So in other words, if I take, it's silly, but if I took desflurane and poured it into a sevoflurane vaporizer, and I turned it on 2%, I won't be getting 2%. I'd probably get a lot more. It would be the wrong concentration. Then you'd have a tragedy. Now, fortunately, we can't do that. The vaporizer is designed so only the right drug can be poured into the right one. So they're kind of idiot-proof where the idiot is. And that's a good thing. So it's not a real clinical issue, but I just want you to be aware of what these numbers kind of mean as far as the gas goes, so you have a feeling for what's going on. Molecular weight is just, of course, the weight of the carbons and hydrogens and halogens and so on. We know the oil gas, we know the blood gas. Is there any preservatives in it? No. Some of the older anesthetics were not stable when you put them in a bottle and stick them on the shelf. So they put preservatives in there. When I was in school, we used a lot of halothane, and it had a preservative in it. It was called thymol, and it used to gum up the vaporizers. So every Friday afternoon, all the students had to go empty the vaporizers. It was our job because we were the lowest on the totem pole. We'd have to empty the vaporizers and wash them out with ether so that we get all the gummy stuff out of the inside. Then we left the vaporizer open all weekend and dry it out, so the Monday they come in, they'd have clean vaporizers. So that was always the student job. Fortunately, nowadays, you don't have to put preservatives because these are very stable molecules, and no problem. Okay, stable and moist CO2 absorber, and of course, other than Sevo, which can possibly produce compound A if you use the wrong granules, which we don't anymore. The other ones are stable. And how much are they metabolized? This is from Barash's table. He says 2 to 5%. My book says 5 to 8%. I know it's confusing. And it's what the way medicine is.
You're right.
Of course I'm right. At least I'm right on my tests. When Dr. Barash gives you a test, right 2 to 5. And the rest are trace amounts, so they're just small. So that's the metabolism. Okay, now, next what I want to do, I'm going to go on this computer. And I'm going to show you I got some PowerPoint slides. Oh, I've just had them over the years. Some are of older anesthetics, but the point's the same. There's no rhyme or method to them. They're just kind of random. But it'll remind me to say stuff before we move on. So let's take a look at some of these. And if you care, I can have Clinton put this on the website. All right, so let's go through some of these. This is a graph depicting, obviously, the MAC of DES with and without nitrous oxide. So the yellow line is desfrane and oxygen, and we're plotting the MAC versus age from 0 to 50 years old. And the red line or orange line is desflurane and nitrous along with it. So I noticed two things here. I'm getting out of this two things. Number one, that both of these lines go down the older you get. So the MAC decreases with age. It takes less to put an old person to sleep than it does a younger person, and Dr. Barash says 6% per decade. The second thing is the MAC of DES, dose of desflurane, is higher when you just give oxygen than when you give nitrous oxide. Right? Why would that be? Pretty obvious. Right? The nitrous is an anesthetic also, so you don't have to give as much of DES. So, there we go. Same thing, this is the MAC of an anesthetic These are plotted against a month, 0 to 1 month, 1 to 6 months, 6 to 12 months, then up to 5 years old, and then all the way up to 60 years. And you see the MAC tends to peak at around 6 months. So it takes about a 6-month-old youngster, the highest amount, and then of course it goes down with age. This has to do with desperate tachycardia. This is from the company, and it's characterization of the increase in heart rate and blood pressure following DES. It's a transient response. It does not occur in all patients. In fact, data shows it occurs in about 15% plus or minus of patients, usually young healthy ones, and treatment is usually not needed due to the brief duration. Everybody treats it with fentanyl. Anytime a heart rate, when you spend any time in an operating room, this is what happens. I could be in a coma, given anesthesia. As soon as the heart rate goes up, everybody in anesthesia gives fentanyl. That's what we do. That's always the first response. So, recommendations to avoid or minimize it, considering the use of IV opiates, prior to increasing concentrations. Start at initial vaporizer settings of 3 to 6. Put the couple breaths, put it up 1%, couple breaths, put it up 1%. Or you could use a short-acting beta blocker. We wouldn't do that, it's overkill. So anyways, have a little art of anesthesia. Turn the vaporizer up slowly over a minute or two. Don't just blast it all in. It's not as irritating. Give them a chance to get used to the smell. Even though the patient's asleep, they still are going to be irritated from the drug. Oh yes. This has to do with coronary blood flow in the inhalation anesthetics. And what happened was, back in a long time ago, I can't remember what year, isoflurane was the most popular. This is before SIVO and DES. We were using isoflurane for most everything. And there was some suggestion from animal studies that isoflurane caused what's called coronary steal. So let me go off on a tangent here and explain what that means. When you have, when there's ischemia in the heart, this is normal physiology. All of us have this. When there's ischemia somewhere in the heart will automatically send less blood to the normal areas and try to shunt blood into the ischemic area. It's trying to help get rid of this ischemia. That's a natural reaction. And to try to help prevent the angina attack or for whatever, the MI, whatever. So that's the normal physiology. If you give a drug that's a coronary vasodilator, and it just dilates all the heart vessels, equally, what happens is you can produce a phenomenon that's called coronary steal. The heart's trying to send the blood where it's needed most, in the ischemic area, then you thinking, oh, geez, I'll give a coronary dilator, and this will be good for the patient because then they'll be getting more blood to the bad area. But instead, you steal the blood from the bad area and send it back to the good area. You work against the body's own physiology. And that's a very prominent effect that can occur with certain coronary dilating drugs, anti-anginal drugs, which we're going to talk about in great detail next semester. So some books call it the reverse Robin Hood effect. The Robin Hood effect in the heart is that you're stealing from the rich and giving to the poor area. And if you reverse that, you're stealing from the poor and giving it back to the rich area that doesn't need it. See? That's called coronary steal. So there was some evidence in dog studies and some rabbit studies that isoflurane produced coronary steal. Now this was the anesthetic, number one anesthetic we're using for heart surgery. So all these people are having cabbages, hundreds of thousands of people a year, and then we're giving them a drug that makes their heart ischemic. That wouldn't be good, right? So we did studies, and this is the control here. Now, if you look on the bottom, can you follow my little cursor? adenosine is well known to produce coronary steel. Everybody knows it. So they're using this as the measure to find out. So what happens is they take an animal, they occlude the LAD or circumflex coronary arteries on purpose. So they produce ischemia in the heart, and then this is the control amount of blood flow into the ischemic area. Then they give adenosine and look at how much blood flow is in the ischemic area. And what do you see? Less, right? You're stealing blood out from the ischemic area, you're making it even worse. And this is, they know this is kind of the control. Now here's ischemic area, control, C, and this is under isoflurane anesthesia. And what do you see? Control area, desflurane anesthesia. And what does it show you? Same flow, right? So does isoflurane or desflurane cause coronary steel? Is the question. And the answer would be no. They're safe. Does everybody see that? It's safe to give them to ischemic patients, and let's face it, people with angina, that's probably I would say, number one or number two disorder that we see in surgery every day. Every day somebody's coming in with some kind of coronary artery disease, even if it's mild. Hypertension, we see that every day. And some of these things are just everyday occurrences. So you don't want to be giving drugs that mess the heart. And the inhalation anesthetics do not do that. SIVO is tested and it doesn't do it either. So they're safe. All right, this is post-op shivering. And of course, this is a concern. As you know, even in your short time in anesthesia, you're already learning that we do a tremendous number of maneuvers to try to keep the patient from dropping their temperature during the case. It's a natural occurrence that, number one, the inhalation anesthetics depress the brain temperature regulating center. Number two, they vasodilate, so they would tend to make the patient lose heat, and they depress the brain's ability to compensate. That's two drug effects. And number three, they're in an OR, the room's cold, they're naked, you're putting all this scrub solution on them and they're getting them wet. You open up their belly and all their body heat's coming out of their abdomen or chest or whatever you're operating on. So it's just not a good situation. And patients are prone to, you're giving them cold fluids, you're giving them cold gas through the endotracheal tube. So for many, many, many reasons, patients' temperatures drop. The question was, is this a drug effect, or is it just the fact that their temperature dropped? So these studies, and they've done with all of them, I just put a couple here. This is looking at patients' temperatures, 34, 36, 38, normal temperatures, 37, right? And how many went to the PACU and shivered? So if you look at this, 37 degrees, pretty much nobody or just a few were shivering. So it really is, what this means is it's not a drug effect. It means that if they're shivering, like these patients are down here at 34, the reason they're shivering is because their temperature is 34. It has nothing to do with what agent you're giving. So anybody can shiver no matter what drug we give them. It's a function of operating room, and we do as just like they do in ICU. We give fluid warmers and bear huggers and all the rest of the stuff we do. And you'll be dealing with all this stuff. So the anesthetics do not cause especially shivering. It's just a matter of keeping the body temperature up so the patient doesn't go get cold in the case. Sometimes easier said than done. This is a study looking at uronosmolarity. What happens is, this is a lab test. Well, it's an animal test, actually. And it's called a vasopressin challenge. Vasopressin is an antidiuretic hormone. And if you inject the vasopressin into a living person or animal, then what happens is you have less water and your urine is more concentrated. So the osmolality goes up. That would be a normal response. you'd expect if you're giving somebody antidiuretic hormone, you're going to have less water or diuresis, so the urine osmolality is going to go up. That would be the normal response. So they're plotting the urine osmolality versus how many hours after they injected 2.5 units of ADH sub-Q, and you see what happens no matter what the anesthetic is, and SIVO does, it doesn't matter. The urine osmolality goes up just like it's supposed to. So what's the take-home message from this? The kidneys still work when you're asleep. You can still concentrate urine, and kidneys respond to the normal hormonal influences and so on. So even though the anesthetics depress the kidneys, it's a mild depression, and they can still function normally, whatever the anesthetic is. Right? Does that make sense? These are just some hormone releases, and they're looking at awake, pre-op. This is 15 minutes after induction, 30 minutes after induction, 60 minutes after incision, and in post-anesthesia recovery. The dashed line is cortisol, steroid levels, and the solid line is growth hormone. And what do you see? When you have surgery, what happens to steroid levels? They go up, right? That's normal. Steroids are released in the body in response to stress. Well, the surgeon just cut you, that's pretty stressful. We shoved a plastic tube down your throat, that's pretty stressful. You're having an operation, that's pretty stressful. So there's all these stresses on the body, and you would expect that cortisol levels would rise. That's a protective and anabolic effect in the body, and that's what's supposed to happen. You're going to see that next week when we start with the IV drugs, one of our induction drugs actually suppresses the release of cortisol, and that's considered a very untoward side effect. So this is normal. You expect cortisol levels to rise, growth hormone also. I don't know if you get taller when you're asleep or what. This is autonomic nervous system function, measuring it, starting at 100%, in other words, pre-op, and then all the way up to 2% fluorine. And what happens is what you'd expect is a dose-dependent decrease in the stress response, the autonomic nervous system response, and the deeper you go, the less responsive you are. So sympathetic activity and parasympathetic activity go down in a dose-dependent manner. That's why we go to work every day, to make it go down so somebody can have an operation. This is intraocular pressure. I stuck this on here. They're comparing two different pre-meds. I don't care about that. But I stuck it on here to remind myself to talk about intraocular pressure. And I kind of touched on this before, but I will say it again. We are concerned about intraocular pressure in certain situations. In some operations, you can't, eye surgeries, you have to make sure that you don't raise intraocular pressure, because that can cause extrusion of the liquid in your eye, aqueous humor and so on, and it can cause eye damage. So in certain trauma eye cases where we do surgery, most eye surgery is done on a local or an IV sedation, but if there are occasions where we do it once in a while, have to put patients to sleep, especially if they get something cut in their eye and so on. And so we don't want to give drugs that make the eye intraocular pressure go up. And again, there's only two drugs we give that make the intraocular pressure go up. One is ketamine, the other is succinylcholine. Neither of those is the gas anesthetics, which is what I'm talking about here. So all they're showing is the deeper you go, the lower your intraocular pressure, and that's good. That's what we want to happen. Okay? We'll talk more about it when we talk about succinylcholine next semester. This is what happens to the neck of the anesthetic if you get cold. This is normal body temperature. This is 32 degrees. This is, you must be dead. You're 27 because you got icicles coming out of your ears. All right, we occasionally get down to slowing heart surgery. Because when you put them on bypass and you stop the heart, you can cardioplegia and you get cold and so on. So this is not compatible with life here. So this is the initial MAC, normal body temp, and you can see the colder you get, the less it takes to put you to sleep. That's kind of makes sense. Oh yeah, that's exciting. This is the FA over the R5, rate of rise in the alveoli over time in minutes for the first 30 minutes of the case. And we already know this. These are a function of the blood gas solubility coefficients. Nitrous oxide, DES, SIBO, fluorine. That's how fast they work. Remember that even though DES is a little bit supposed to be faster than nitrous, in reality nitrous goes in a little faster because of the concentration effect. Because we give 70% versus 8 or 9% DES. That's it. Let's take a break. Okay. To wrap this stuff up, I want to say a couple things. Number one, the Inhalation Anesthetics are Chapter 8 in the textbook. I'm begging you to read it. We'll cover all the stuff we just covered.
You still owe us dinner. Reading class.
Oh, yeah. End of semester, I'll take you out.
We have that on recording, by the way.
Yeah, I know. That's unfortunate, man. I want to play you a video. And I don't know why that's blinking. This is a little video by Dr. Ager, and every year I decide whether should I use it again. It's a little old. You know, I watched it again the other day, and it's still current. And what a nice way to summarize and wrap this up, I think, is to hear from the man himself. He talks about he was the one who brought desflurane to the market, did all the initial studies and all that, and he talks a lot about that. As Mike let me know, he recently passed away, I think about 2 months ago. Several people have told me that. And in fact, Art sent me his obituary out of the New York Times. If I didn't mention before, I probably should, I just thought of it. Dr. Art Hupka is a pharmacologist from Salt Lake City, Utah, and he's faculty at Westminster Anesthesia program in Salt Lake City, and he is on most of these classes with me, and we talk about usually weekly or every other week about some pharmacology topic. He sends me a lot of material. You'll notice in this book as we get farther along, some of the tables and all that stuff is by him. And I joke with Art that he's a real pharmacologist. I just played one on TV. But he's very helpful and a very nice man. And as I said, he sent me Dr. Ager's obituary out of the New York Times a couple weeks ago. So unfortunately, but he had a good run. So let's see if I can get this to work without calling him. This lasts about 40 minutes, and then that'll be the end, and I'll see you next Thursday. So let's watch this, and then that's the end of the class.
Okay. We're can talk about it in the larger context, the context that we use every day. The division of anesthesia into 4 interrelated states or parts or times that form a continuum. From before anesthesia to induction to maintenance of anesthesia and to recovery from anesthesia.
Is that shown in the map?
We'll consider these in sequence,
Fine.
remembering though that one affects the next and that they are a continuum. What about the preoperative visit? What's the point of that visit? Well, the point is that the patients who are about to undergo anesthesia should be terrified. How many of you are terrified of being anesthetized? How many? Yes. That's why you went into anesthesia, so you'd have control. And when you're anesthetized, you don't have control. The anesthetist has control of everything. Of your brain, your heart, your breathing, your muscles. Everything is controlled by that person who's going to take your life in their hands. And you've got to have confidence in that person. So how do you gain the confidence of your patient, this terrified person, who not only is giving up control, but is faced with dangers such as mutilation, pain, and death? Maybe the discovery that they have cancer. How do you establish that relationship? Well, one thing you do involves faith. You've got to have faith in yourself. How many of you believe that you are the best anesthetist in the world? Any more than one of us. But I believe that. I know it's wrong. I know intellectually. I know I'm not. The resident who's supervising me is probably better than I am about 2/3 of the time. He or she gives more anesthesia than I do. But I believe, I have faith that I am the best anesthetist, and I convey that confidence to my patients. And you need to do that too. You need to establish physical contact with the patient. You come in and you say, Mr. Jones, I'm Dr. Eager, and you shake his hand. You touch his shoulder. Establish physical contact with the patient. And you discuss things slowly or unhurried. You're talking in a normal voice. You're not shouting at the patient. Some residents come in and shout at the patient. They're afraid they won't hear all those words of wisdom you're about to convey to the patient. And they'll have a voice that's 2 or 3 octaves above their normal. They're terrified. They're as terrified as the patient is. Herb Andrew, one of my previous colleagues, came up to me. He was talking about one of our friends, one that I talked to you about a moment ago, Eric Warnbrock. Eric Warnbrock was asked by one of the residents, Dr. Warnbrock, how long does it take before you begin to have confidence that you're going to be able to anesthetize a patient? And wake them up. Wake them up afterwards. And Eric said, well, he said, I don't really know. But I do know that I did have a solid stool for the first 3 months of my residency. So you've got to be confident. You have to not be terrified. Establish physical contact with the patient. Show your concern. Show your concern. And by that, decrease the terror of the patient. And of course, if that fails, you've got the 2 milligrams of potassium. As I'm going to tell you, there's a price that you pay for the 2 milligrams of potassium. Okay. Now, for induction of anesthesia, you want to establish the anesthetic state quickly. You want to go from awake to asleep quickly. You want to go through this phase, which is frightening to patients quickly. You want to do it pleasantly, but you want to do it safely. And at the same time, you've got to anticipate maintenance and recovery. You've got to anticipate that what you do during induction may affect how quickly the patient recovers from anesthesia. That what you do during induction may affect how they respond to instrumentation of the airway, how they respond to the surgery that will be ongoing. Now, there are two approaches to induction of general anesthesia. Inhaled and injected. That's pretty obvious, isn't it? Why do you choose the inhaled approach? Well, for kids, it's kind of obvious why you would choose the inhaled approach to anesthesia. I remember how frightening it was to go to the doctor's office and have a shot. I don't know why. Maybe kids are just more sensitive to needles than adults are. It's something that no longer frightens me or concerns me. And yet I know that with many adults that carries over into adulthood. I remember being at the bedside of the patient where a resident was starting an idea, and even I was beginning to be uncomfortable because there was the 10th attempt. And about that time, there was a clunk, and I turned around, there was the patient's husband on the floor. But kids are particularly sensitive. And we induce anesthesia by an inhaled approach with sevoflurane. And pretty much all of us do this now. Why sevoflurane? Well, because the alternatives are unacceptable. Because desflurane, for example, causes respiratory irritation. This is the percent of unmedicated patients breathing anesthetic at 2 MAC who complain of respiratory irritation. That's 75%. And almost 50% of those given isoflurane at 2 MAC complain of respiratory irritation. But nobody given 2 MAC of sevoflurane complains of respiratory irritation. It's simply not pungent, whereas isoflurane and desflurane are not pungent. Desflurane more than isoflurane. So we use sevoflurane for induction of anesthesia in children. But adults prefer an intravenous induction of anesthesia, particularly now with propofol. That's pretty much the standard. And why propofol rather than sevoflurane? Well, it provides a quicker induction. It's smoother. It's antiemetic, whereas sevoflurane and all the inhaled anesthetics, I don't want to pick on sevoflurane, desflurane, isoflurane, all cause postoperative nausea and vomiting, and propofol decreases postoperative nausea and vomiting. Propofol can produce euphoria. Makes you look good. Have a patient wake up and be delighted to be there. But most important of all, an intravenous induction of anesthesia avoids the claustrophobia from an inhalation induction. These data are from Suzuki's publication in the Journal of Anesthesia. Suzuki did a very simple experiment. He anesthetized half of his patients with sevoflurane and half with propofol. And then he went around afterwards and he asked the patients if they were willing to have the same anesthetic again. Only half the patients given sevoflurane were willing to have the same anesthetic again, but 90% of those given propofol. And the difference is the claustrophobia that is associated with an inhalation induction of anesthesia. What do we want to do to maintain anesthesia? Well, we've got to consider safety. That's paramount, of course. We've got to develop adequate surgical conditions. We'll go into what that means in just a moment. But it's very simple, and we can do it. We have to be able to deal with changes in surgical requirement or in patient physiology. And we have to anticipate the need for a rapid and smooth recovery, at least in most patients. What does the surgeon want? We know what the surgeon wants. The surgeon wants only 3 things. Am I not right? That's what the surgeon wants. And we can deliver all of those things. Well, maybe not the 1-minute turnover time. But we certainly can deliver cadaveric relaxation if we need to. And we can produce an immobile patient. What do we have to do to produce an immobile patient? We have to supply anesthesia. Anesthesia that we can control, and that means we give an inhaled anesthetic. In this case, it's desflurane, but it doesn't matter whether it's desflurane. It could be isoflurane, it could be sevoflurane, it could be halon. The result would be the same. This is from a study of office-based anesthesia by Tang and coworkers, and indicates the percent of patients moving during surgery with desflurane versus with propofol. These are general anesthetics. propofol nitrous oxide versus desperate. So why do the patients given propofol tend to move much more, 40%, whereas only 5% of the patients get desperate? And the answer is simple. We know on a breath-by-breath basis how much desperate we're giving. Not only how much we're giving, but how much the patient is seeing, what the active anesthetic is, what the partial pressure is. We have no idea what the partial pressure is of the propofol that we're giving. There is no moment-to-moment analyzer of the effect of propofol. Oh, you say, well, there's a BIS monitor. But the BIS monitor is intended to tell you whether the patient is awake or not, whether the patient is conscious or not, whether the patient is amnestic or not. It's not intended to tell you whether the patient will or will not move. In fact, the aspect people will deny that that is what it will do. It will not predict whether movement will or will not occur. And that's been tested. It won't tell you whether movement occurs. In fact, there aren't any measures that will tell you whether movement will or will not occur. There isn't an ED50 that you can get from a device that measures brain waves, for example. Hardly a surprise given that anesthetics don't act in the brain, they act in the spinal cord. We need to have optimum control of patient physiology, which is important. It didn't used to be important. In the days when we were giving ether or inhalant, the surgeon had no idea what we were doing. But now the surgeon and everybody else in the operating room knows what we're doing. They hear that thing going beep, 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 beep. And when it goes beep, 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 they know something's gone wrong and they look at you. You're not giving optimum anesthesia, are you? What's wrong? Why is the blood pressure 40/20? You could hide that. They had no idea when you were measuring with that sphygmomanometer, but now it's right up there on the screen. So you've got to maintain normal patient physiology. And you've got to know something about the pharmacology of the anesthetics that we deal with. The pharmacology of the inhaled anesthetics across anesthetics is far more similar than it's dissimilar. But you've got to know both what it does, what they do, and what they do similarly and what they do differently. There's some important differences. And remember this, I showed you as an important difference among the anesthetics, with desferrin and to a lesser extent isoflurane being pungent anesthetics, whereas sevoflurane is not a pungent anesthetic, which makes it very useful for the induction of anesthesia. But I can show you the same slide, there's no difference. What's the difference between this slide and this slide? Besides the fact you've got some bars that are white on one and no bars on the other. You're very smart, you're right. 1 versus 2. At 1 MAC, nobody complains of respiratory irritation with desferrin, isoflurane, or sevoflurane. We discovered this with the first administrations of desferrin, which were done in England. We went to England because we didn't kill anybody in the United States. So we're testing desferrin in London, and because we were a little apprehensive about what this new anesthetic was going to do, we didn't give more than 6% desferrin to these volunteers, some of whom were part of the experimental team. Volunteers received desferin, very brave people. None of them had any respiratory responses to the desferin. None of them had any breath holding or coughing or spasm. And in fact, we had to instrument the airway in several of them because they got obstructed. They went to sleep. And we could put an oral airway in at 3 or 4% desferin. They didn't respond to that. We thought it was going to be a marvelous anesthetic for induction of anesthesia until we went back to the United States and tried to induce anesthesia at concentrations that exceeded 6%. And when we got to 7 and 8%, they resented it. And there was laryngospasm, there was coughing, there was breath holding. But at 6%, desferrin looks just like isoflurane or sevoflurane, which has some important clinical implications, particularly with the use of LMAs today, because the concentrations of anesthetics that are required for maintenance of anesthesia, given via an LMA, are much the same. And that means that, in fact, the respiratory responses or the inhaled anesthetics are all pretty much the same for maintenance of anesthesia given via an LMA. So the incidence of coughing during anesthesia while breathing through an LMA is the same for desfrane as it is for isoflurane, as it is for sevoflurane, as it is for propofol and nitrous oxide. They're all the same because none of them are really irritating at the concentrations given for maintenance of anesthesia. There's a second reason which I didn't go into when I discussed this. I said anesthetic concentrations used for maintenance are usually less than 1 mg. That's below the concentration which is touched. But in addition, we often, for good reason, give opioids. And those opioids further diminish the perception of airway stimulation. Not content with the data that I showed you in the previous slide, this one, we did a study that was just published in Anesthesia and Analgesia. Rachel Ashima did this study, looking at the percent of patients coughing while breathing through an LMA and directly comparing sevoflurane with desfrane. And the point of this slide is to say that the incidence of patients coughing is identical with sevoflurane versus desfrane. There's some other nice similarities among the potent inhaled anesthetics. One of them is their capacity to dilate constricted bronchi. You take a rat and you constrict the rat's airway by giving it methacholine. You measure the airway resistance that's consequent to the administration of the methacholine. You find that it's 200% of the control. And then if you add halothane or isoflurane or sevoflurane or desfrane, you find that the airway resistance decreases by about half or a little more at 1 mg. And still further, that you can relax those constricted bronchi by the administration of any of the potent inhaled anesthetics. There's nothing really to choose among them. They all produce relaxation of constricted bronchi. What about the circulation? Well, during steady state, during maintenance of anesthesia, you can't tell them apart. It's only during induction of anesthesia that you can tell them apart. Here's a slide illustrating the fact that they're all very much the same during maintenance of anesthesia. This is from a study that we did in volunteers who were exposed on one occasion for 8 hours to 1 1/4 mg desfrane, and on another occasion to 1 1/4 mg sevoflurane. 9% desfrane, 3% sevoflurane. And the point of this slide is to say that the heart rate and the blood pressure for these two anesthetics were indistinguishable. They're the same. If you had isoflurane at 1 1/4 mg, you'd see, I think, essentially the same result for maintenance of anesthesia. But during induction of anesthesia, there's a difference. And this was first brought to our attention by Tom Ebert, who showed that if you took a volunteer and anesthetized the volunteer at 1 mg, that's the vaporizer valve setting, 1 mg, and then at time 0, you increase the vaporizer setting from 1 mg to 1.5 mg. If that anesthetic were sevoflurane, the heart rate decreased. Not a great deal, but it decreased. Didn't increase. In contrast with desfrane, it increased transiently, but certainly significantly. It increased, and then it came back down towards normal. Weisskopf found a similar result for desfrane. Found that with desfrane, if you took a volunteer and anesthetized them with 4% Untitled desfrane, these are paralyzed volunteers instead. And then at time 0, you increase the Untitled concentration from 4% to 8%. Suddenly, within a minute, that the arterial blood pressure went from this control level to double it. Double it. This effect was only brief. It lasted 4 minutes. Back down here to normal. 4 minutes later. Now, Weisskopf did what I think was an even more interesting experiment. He then returned the concentration to 4%, held it for an additional 30 minutes, and then repeated the step change from 4% to 8%. The second time he did it, he found that the blood pressure change was trivial. He did it a third time and found that the blood pressure change was trivial. So desfrane can stimulate rapidly adapting receptors that may cause cardiovascular changes that we don't like to see in patients with coronary artery disease. We don't mind it in young patients, perhaps, but we do mind it in patients who are in danger of myocardial infarction. Sevoflurane, on the other hand, doesn't have this. And is a nice anesthetic, a smoother anesthetic for those patients. Smoother, unless we can deal with this problem with desperate. Well, we can deal with it. Like the respiratory irritant effects that I showed you before, as long as you stay below 6%, you don't get this effect. If you go above 6% and do it slowly, you get much less of an effect. And if you give opioids, you get much less of an effect. The previous slide that I showed you was in the absence of opioids. That's what gave this result. This is heart rate instead of blood pressure, but the same effect is seen. A step change from 4 to 8% produces this doubling of heart rate in the absence of the opioid medication. Returns back to normal in about 5 or 6 minutes. If you give 100 mics of fentanyl, you can see that this effect is reduced by more than half. You give 3 times that, and it's reduced still further. Now there is a nice side to the inhaled anesthetics. A nice side in that they may add an element of protection to the heart. We talked about isoflurane and desperane potentially injuring the heart by this cardiovascular stimulation. But desperane and isoflurane and sevoflurane may protect the heart by doing something called preconditioning. The inhaled anesthetics may precondition the heart and protect thereby against subsequent hypoxia. Protect against occlusion of the coronary artery, as may be done for coronary artery bypass grafting. There are very few studies which have shown comparative effects of the inhaled anesthetics. We know they all can protect by preconditioning, but we don't know their relative capacity to do that. This study by Perio, published last year in the BJA, is one of the few comparative studies. It suggests that there might be a difference among the anesthetics. This is a study in which preconditioning for 30 minutes by 1 MAC of an inhaled anesthetic was shown to protect against 30 minutes of circumflex coronary artery occlusion and gravity. That's a subsequent circumflex coronary artery occlusion, when the inhaled anesthetics are no longer even present. So they're given before the occlusion, and they provide a protection. A protection is defined by the determination of the percent of the risk zone, that is the zone supplied by the circumflex coronary artery, that was infarcted. So over half of that risk zone was infarcted in animals that were anesthetized with the baseline anesthetic Carlos. A lesser amount, the sevoflurane, a still lesser amount, and this was statistically significant with isoflurane, and a still lesser amount with desperane for infarctus. This was different from the sevoflurane and different from control. Whether there is truly a difference among the inhaled anesthetics in their capacity to protect the heart is not really known. This is not a sufficient study to prove that point. We need dose response curves. We need to show a repetition of this in a comparative manner. And my hope is that will be forthcoming soon. We want 2 things of recovery. We usually want a recovery that's quick. There are exceptions to that, but we usually want the patient awake soon after anesthesia. And we want a recovery that's calm. Let's look at the factors that determine a recovery that's quick and why it's desirable. It's desirable because it may speed transit through the operating room and the PACU. It may allow an earlier assessment of the patient's neurologic status, and that's certainly important for neuroanesthesia. It may allow for a quicker assessment and control of pain. And it may be safer. This is a slide showing you why it might be safer. This is a fraction of MAC awake. And you can see that the fraction of MAC awake determines the incidence of pharyngeal dysfunction. That is, the ability to swallow normally. At 1/4 of MAC awake, that's 1/10 of MAC, at 1/4 of MAC awake, there's pharyngeal dysfunction in more than 25% of patients given propofol or isoflurane or sevoflurane. And if you'd had desperate or halothane, I think you would find the same thing. Well, it wasn't studied in this study. So a very small amount of residual anesthetic, a tenth of MAC, impairs pharyngeal function. A quarter of MAC weight. These patients are all awake and talking to you, but they've got pharyngeal dysfunction. They don't swallow enough. So getting rid of the anesthetic, getting back to zero as quickly as possible, adds to the safety of your anesthetic. There are two factors that determine rapidity of recovery. Recovery in the sense of the patient who is responding to you. One is the elimination of the anesthetic, and that's obvious, but the second is the anesthetic level that permits wakefulness to occur. That is MAC awake. We've been talking about that, and this repeats the definition I've shown you before. Got a question? There surely are. There's certainly effects, not necessarily on pharyngeal dysfunction, but on the perception of a foreign body in the airway. And that will certainly influence the safety of the anesthetic. So this is MAC awake. We've gone through that. It adds to the safety to reach MAC awake because of that concentration. The patient is apt to maintain their airway. MAC awake difference among the anesthetic. MAC awake as defined as a fraction of MAC itself. So for nitrous oxide, the MAC awake is about 2/3 of MAC. And for the potent inhaled agents, isoflurane, desflurane, and sevoflurane, it's 1/3 of MAC. And for propofol, it's less than 20% of the equivalent of MAC for propofol. It means that you only have to eliminate about 1/3 of the nitrous oxide for awakening to occur if you're giving a pure nitrous oxide anesthetic at a pressure change. But you've got to get rid of 2/3 of the desflurane, or the sevoflurane, or the isoflurane before awakening will occur. You've got to get rid of 80% of the propofol if you're giving a pure propofol anesthetic, and you can't. You can give a pure propofol anesthetic, but you've got to get rid of 80% of it before the patient will awaken and respond appropriately. That's the bad news, in a way, of a low MAC awake, or the good news of a high MAC awake. The bad news of a high MAC awake is that nitrous oxide doesn't provide amnesia to nearly the extent that isoflurane, or desflurane, or sevoflurane do. And propofol is the best amnestic agent of all. So you've got to remember this when you're thinking about a quick recovery. And you've got to think about solubility, right? And we know now how important that is to the quickness of awakening. We know that nitrous oxide and desflurane have similar lean tissue solubilities in terms of tissue gas partition coefficients, not tissue blood, but tissue gas. They differ in terms of their fat gas partition coefficients. Nitrous oxide has 1/10 the solubility of fat that desflurane. Desflurane has about half the solubility on average for all tissues that sevoflurane has, and sevoflurane has about half the solubility of isoflurane. And we predict from that, and our knowledge of MAC awake, that awakening is going to be quicker with desflurane than with sevoflurane, and quicker with sevoflurane than with isoflurane. And the data that we have suggests that's true, including data after prolonged anesthesia. In fact, particularly after prolonged anesthesia, where you deposit anesthetic in some of those deeper depots like fat and muscle, particularly muscle. That anesthetic comes out of the muscle into the venous blood, where it then moves to the lungs. Now, if it's cleared at the lungs, if the anesthetic is poorly soluble, then it won't recirculate and delay recovery from anesthesia. But if it's a moderately soluble anesthetic, then a substantial fraction of the anesthetic will recirculate, and that will delay recovery. As we predicted, the less soluble anesthetic allows a more rapid awakening. This is from Ebert's work. Ebert went to the Abbott database to retrieve data for sevoflurane versus isoflurane. These were done in prospective, randomized, multi-center studies, and showed that the patients given sevoflurane were oriented sooner after a 3 to 5 hour anesthetic than those given isoflurane. The asterisk in this and in subsequent slides shows a statistically significant difference. And the same thing is true of patients given desflurane versus isoflurane. This is for a 5 hour anesthetic. Patients given desflurane opened their eyes sooner. There's the little asterisk. And they were fit for discharge about 40 minutes sooner. Notice the log scale. 40 minutes sooner than those given isoflurane. And recovery is also quicker after desflurane than after sevoflurane anesthesia. The number of peer-reviewed studies in which awakening was significantly quicker after desflurane than after sevoflurane is 40. And there are none where awakening has been shown to be significantly quicker after sevoflurane than after desflurane. Here's an example of one such study. This is from Mahmoud's work. A study in office-based anesthesia, brief anesthetic experiences. 60 patients are randomly divided into 2 groups for minor gynecological surgery. All patients have 50 milligrams of fentanyl given as part of their pre-medication, and anesthesia is induced with 2 milligrams per kilogram of propofol. Anesthesia is continued with nitrous oxide plus either desflurane, that's half the group, or sevoflurane, given via an LMA, at concentrations that are slightly less than 1 mg. So I need not tell you that there are no difference in the respiratory response of these 2 groups of patients. But there was a difference in terms of recovery, with the patients given desflurane oriented sooner and ready to leave the PACU sooner. Notice how quickly these patients were ready to leave the PACU. 16 minutes in the case of desflurane and 24 minutes in the case of sevoflurane. Very quickly for both of these poorly soluble anesthetics with patients ready to leave the PACU. And that has some implications for whether it's worthwhile choosing desflurane or sevoflurane or isoflurane. If your PACU says, well, we got to keep all patients for 2 hours, it doesn't make any difference whether you choose desflurane or sevoflurane or isoflurane or gasoline. They'll be ready for 2 hours. But if you want them to leave sooner, you want them to leave the OR sooner, you want them to be awake sooner, you want them to have pharyngeal function return sooner, then the less soluble the anesthetic, the quicker will recovery occur and will the patient be able to meet those endpoints. We need a recovery that's calm, and that means 3 things. We need to anticipate. We need to anticipate the response to a tracheal tube removal, to pain, and the potential for nausea. It didn't always used to be the case that we needed to anticipate the removal of the endotracheal tube. We didn't need to anticipate that because the anesthetics that we used long, long ago, anesthetics like diaphragm or halide, or to a lesser extent isoflurane, didn't allow recovery to occur so quickly. So the patients remained anesthetized and unaware of that foreign body that was tickling their airway and whose removal stimulated the airway. But with these newer anesthetics, with anesthetics like desflurane and sevoflurane, awakening is so quick that the patients remember that foreign body and its removal. Just as if you drank some water and it went down your airway and you coughed it out, you'd remember the foreign body that had been in your airway, and you continue to have some element of laryngospasm for 2 or 3 or 4 minutes. And you continue to cough, even though the water is long since gone. So how do you deal with this problem? Well, you can manage it with a deep extubation, meaning you continue the anesthetic, the desflurane or the sevoflurane, until right before you remove the tracheal tube. But most of us taper the anesthetic, regardless whether it's desflurane or sevoflurane or isoflurane. We're anticipating getting to that removal of the tracheal tube, and we want to have the patient awake quickly afterwards. We can still have the patient awake quickly afterwards if we give something that transiently deepens the anesthesia, enough so that the remembrance of that foreign body in the airway is diminished, maybe 10 to 20 milligrams of propofol. Or we can give an opioid like fentanyl, not morphine, not morphine, that minimizes the perception of the foreign body in the airway. Why not morphine? Well, because morphine takes about 45 minutes to reach its peak effect, whereas fentanyl reaches its peak effect in perhaps 7 minutes. And we want to titrate the amount of fentanyl to an endpoint. You can't do that very well with morphine. You can't do it in a timely manner with morphine, but you can with fentanyl or remifentanil or alfentanil. And we want to remove the tube with the lungs fully inflated. That's not to say we inflate the lungs and allow them to come back to the FRC. It's to say that we inflate the lungs, and with the lungs still inflated, remove the tube. Because the first thing the patient must do, if that's the maneuver we've imposed, is exhale. The first thing the patient will do then is push out any foreign material that happens to be in the airway into the pharynx, rather than, as would be the case if the patient's lungs were at FRC, take an inspiration and draw that foreign material into the lungs. And pain. How do we deal with pain? Well, first we have to know what conditions predict pain. So if you ask patients after surgery whether they are in pain, you get some gauge of measure of pain, you find that women complain of pain more than men. Now, I'm just the messenger. This is just quoting Damani's work. I'll just come with here from the BJA. Whites complain of pain more than African Americans or Asians. And the rest is pretty obvious. You got major surgery, you got more complaints of pain than with minor surgery. If the surgery is longer, you got more complaints of pain. If you haven't given any opioids, you got more complaints of pain. And if the time for the last opioid is greater, you've got more complaints of pain. So to control pain, you have to first anticipate whether there's going to be pain. You have to think about the patient of the surgery, decide whether the pain is going to be minimal or it's going to be considerable, and act accordingly. If you think it's going to be minimal, administer some COX-2 inhibitor or give some ketorolac. If you think it's going to be more than minimal, then you may want to give a rapid-acting opioid, fentanyl, or to a respiratory rate. That means you've got to have the patient breathing for the end of anesthesia. And get the respiratory rate down to 10 to 12 breaths. If you really think the pain is going to be considerable, you may want to consider giving both the opioid and some ketorolac. And you can ask your surgical colleague to help by injecting local anesthetic. Who's going to be nauseated? The young woman having a laparoscopic or plastic procedure. The patient who gets drugs which predispose to nausea and vomiting, opioids, not fentanyl, not propofol, higher concentrations of nitrous oxide. The patient who requires the administration of substantial doses of neostigmine, more than 2 milligrams of neostigmine, is more prone to nausea and vomiting. So how do you avoid nausea and vomiting? Well, you don't anesthetize young women who are having laparoscopic procedures. And you avoid drugs which predispose to nausea. You can increase fluid administration, particularly of colloid administration, and you can use multiple antiemetics, including propofol. Colloid administration, head start, has been shown this year by Moretti, anesthesia analgesia, to decrease emesis, compared at least to fluid resuscitation with lactate or vegan, or to decrease the need for a rescue antiemetic. If you're really concerned, you might want to think about giving colloid. And you might want to think about using multiple antiemetics, because nausea is mediated not just by one neurotransmitter, but by several neurotransmitters. And you don't know which one is important in this patient or that patient. You may also want to consider the optimum control of anesthesia costs. You may want to use less expensive agents or use more expensive agents at low flows. Either way, you can control costs. You are in charge of costs. So you may want to give desferrine or sevoflurane. They're more expensive. They're more expensive, but you can control that cost. If you give a desperate and sevoflurane anesthetic at 4 liters per minute, that's going to be about a $15 per hour anesthetic. But if you lower that down to 1 liter per minute or less, it gets to an anesthetic of less than $5 per hour. I'm going to skip by this one and go to my conclusions for this. There's no single anesthetic that provides optimum control over the anesthetic experience. I submit to you that the optimum control over the anesthetic experience, though, is obtained by combining several anesthetics and anesthetic adjuvants, and that most of us do this in our practice. And I'm going to go over a recipe that I use for the ordinary patient. Now, I'll appreciate that this is modified for different patients, depending on their physiology, their pathology, and on the surgical need. For pre-medication, that first part of the anesthetic continuum that we considered, you can give nothing on midazolam. And most of us give 2 milligrams of midazolam because we believe that our patients have a midazolam deficiency. Not all patients are terrified. And there's advantage to not giving the midazolam, especially for brief procedures, where the administration of the 2 milligrams of midazolam may delay the discharge from the PAC unit. For reduction of anesthesia, I use propofol for reasons that we've already discussed. And I also use some fentanyl because all patients do have a fentanyl deficiency. And they have a fentanyl deficiency because we're going to do 2 things that require the use of an opioid. We're going to instrument the airway, and we're going to do something that causes pain. We're going to cut them. And none of the other anesthetics are good analgesics. Desflurane is not, sevoflurane is not, isoflurane is not, propofol is not a good analgesic. Yes, they supply some element of energy, but not nearly as well as an opioid does. The importance of an opioid to decreasing respiratory irritation, the perception of a foreign body, or instrumentation of the airway, is shown here. If you give saline premedication, the incidence of patients who cough on induction of anesthesia with desflurane is 25%, but if you give just 1 microgram per kilogram of fentanyl premedication, it's decreased by 80%. Same thing with morphine premedication. And you've seen this slide before, which shows the synergistic effect of the administration of fentanyl on sevoflurane requirement. Same thing applies with desflurane or isoflurane. You need the opioid to decrease the perception of pain that otherwise exists in the potent anesthesia. I maintain anesthesia with the same regimen, differing, 2 regimens differing whether I give desflurane or sevoflurane. They both contain nitrous oxide. I use nitrous oxide because it's cheap, has minimal cardiovascular effects, and it allows a quicker awakening. It has that higher MAC awake benefit. But I only use 50% because, in volunteers at least, 50% seems to be the threshold between no nausea and vomiting and nausea and vomiting. We go to higher concentrations in volunteers, given nothing else, and you find that they're throwing up repeatedly. I use low flow rates. I can use lower flow rates with desflurane than I can with sevoflurane, but I use low flow rates because they're most economic. I use 2 to 6% desflurane, 1 to 2% sevoflurane. These 2 anesthetics, in fact, are indistinguishable in terms of their clinical effect over this concentration range. Remember that 6% is the concentration that reduces or is the threshold for respiratory irritation and for cardiovascular stimulation. So these 2 anesthetics look identical at these concentrations, and these concentrations are all that are needed with the nitrous oxide, a bit of opioid, a bit of propofol to supply a complete anesthetic. I will add more fentanyl if the patient starts to have an increase in pulse rate, showing that the patient is perceiving the pain of ongoing surgery. I got a little insurance policy. I keep a syringe with 3 or 4 or 5 cc's of propofol available in case I'm surprised by the patient. In case the patient has light, unexpected And I'll give as little relaxant as I can, minimal amount of relaxant, to ensure that I can reverse the action of the relaxant, and perhaps don't even need the action of the relaxant to reverse it. For recovery, I may use multiple antiemetics. I may use triple antiemetic therapy, a serotonin blocker, a dopamine blocker, and perhaps some dexamethasone. And with that, I can produce an anesthetic state that produces an incidence of postoperative nausea and vomiting that's equal to that found with propofol. I may use a bit of propofol for removal of the tracheal tube. And I'll use whatever I think is necessary for control of pain, including COX-2 inhibitors, ketorolac, fentanyl, and a local anesthetic. And with that, I think I can deliver a close to ideal anesthetic.
Okay, thanks. See you Thursday. I put this video on my website if you want to look at it again. Thank you.